Good morning, dear colleagues, ladies and gentlemen. My name is Felix C. I'm going to talk about the new ESC Core Curriculum in Cardiology. And the reason for this is that we are planning to implement the new ESC Core Curriculum in our Weiterbildungsprogramm as soon as the core curriculum is published. As you might know, different versions of the core curriculum have been published during the last 20 years. The last version appeared in 2013, and already we have decided to produce a new version of the ESC core curriculum. This has different reasons. An important reason is that cardiology has changed in the last years. We are facing increased demands on knowledge and particularly on technical skills because there are new devices and new interventions. Then it has become more difficult to understand research and its impact on clinical practice. Moreover, we are facing increased demands on assessment of competencies in the clinical context. And finally, patients should be involved in the process of core curriculum generation. In the current version of the core curriculum, we are focusing on skills, and we are focusing on the assessment of these skills and of clinical competencies in an everyday clinical context. We have also involved trainees because in the end we are producing this core curriculum mainly for them. And we have also involved patients because it is very important to include the patient's view in such a document. On this slide you see the task force which was busy with generating this new version of the core curriculum. In dark red you see the nucleus of the task force, which was recruited from members of the education committee. In blue you see the education committee liaison officers to the ESC associations. And in light red you see the remaining members of the education committee. Now the nucleus, the 10 people listed in dark red, did the major part of the work. Each of these members wrote one chapter of the core curriculum, and the remaining members of the education committee and the liaison officers to the associations of the ESC provided important input during several rounds of discussion and revision of the document. And here you see many more people who also contributed, mainly in repetitive discussions and in repetitive rounds of revision of the document. And you see that we took care to involve ESC board members, National Cardiac Society representatives, and among those mainly people from countries participating in the European exam in general cardiology. And down there at the bottom of the list you see representatives of the young community and representatives of the patients. Now these are almost And you probably ask yourself how we involved everybody in these discussions. This is in fact not so easy. We used a method which is called the DelV method, and this consists in repetitive rounds of discussion, if you want. We did that via surveys which were sent out by email, and after each of these surveys we evaluated all the responses, put them together, and decided with the nucleus which of these comments we wanted to introduce into the revised document. And you can appreciate in this schematic that several rounds of such surveys and discussions were required. But in the end, we feel that we could generate a document which really is based on the opinion of many people executing important functions in the ESC and knowing a lot about cardiology. Now let's move to the content of. Another important thing to think about is that during training of an individual, the trainer develops an increasing degree of trust in the trainee's competence. Again, this is something we know from our own clinical experience. A trainer works together with a trainee, a trainer observes the trainee, and a trainer evaluates the trainee in a clinical context. During this process, the trainer develops more and more trust in the abilities and in the competence of the trainee. And this process of building up trust automatically takes into account that each trainee requires a different numbers of exams in order to be able to be competent in a clinical context. So for these reasons, we started to think about trustable professional activities, because entrustable professional activities, or briefly EPAs, are a formalized way of taking individuality in learning and building up trust during this learning process into account. Now, what is an EPA? An EPA is a unit of professional practice which a trainee can execute in an independent manner at some stage of training. An EPA enables the assessment of a clinically meaningful unit of competence. So, for example, assess a patient with chest pain, or assess a patient with arterial hypertension, or assess a patient with a severe aortic stenosis. To complete an EPA successfully means that the trainer has developed sufficient trust in the trainee. Or, in other words, the trainee has reached a sufficient level of clinical competence. On the left-hand side of the slide, you see how an entrustable professional activity in a core curriculum is built up. It consists of a title, of a description, of the ConMeds roles involved. I will get back to that in 2 slides. And then the main body of the EPA is knowledge, skills, and attitudes. And finally, in an EPA, you should define the assessment tools and the expected level the trainee should reach during training. So taken together, the rationale for using EPAs was that we wanted to generate the necessary flexibility for guiding trainees and for assessing trainees under consideration of their individuality, because they have different abilities and different training needs. And the other rationale for using EPAs was that EPAs allow and promote a holistic assessment in the clinical context, because they focus on clinical competencies and clinical skills in an everyday setting. So briefly, let me show you how the core curriculum is constructed. We have 9 chapters. Chapter 2 to 9 cover a major topic of cardiology. You see that listed in red letters. And chapter 1 is a more general chapter. It is called The Cardiologist in the Wider Context. And it blends into all the other chapters because it defines the different roles a cardiologist should be able to take while doing clinical work. And these roles, these professional roles, have been perfectly defined by the Canadian Medical Society. It's called the CanMed's Physician Competency Framework. So we decided to officially implement this system. And in each of the EPAs, you will therefore find a part which defines the CanMed's roles involved in this particular clinical competence. This slide shows you the different chapters and the different EPAs. So all in all, we have 62 EPAs in this core curriculum. When you have a sufficient level of competence in all of these 62 EPAs, you really have a very broad education and training in cardiology, and you can work perfectly well in clinical practice, being that in a private practice or in a hospital. This shows you how an EPA looks like. This is just one of those 62 EPAs. This particular EPA defines how we manage a patient with aortic regurgitation, and you can appreciate the different sections of the EPA with the description, the CanMed's roles, the knowledge, skills and attitudes, the suggested assessment tools, and finally also you see the related ESC topic list numbers. This is something I have not mentioned before, but this is something which seems important to us, that each of these EPAs is linked to the ESC topic list. The idea behind this is that it should facilitate learning, because the ESC topic list allows you to gather information on the ESC homepage, and this is different information. This is clear: case reports, systematic literature, and textbook, the ESC textbook. Now I mentioned that each of these EPAs defines an entrustment level or an independence level. And you see on this slide the 5 levels of independence we have defined. This is nothing new, we have adapted that from the EPA literature. And you see that level 1 is that the trainee observes. Level 2, the trainee is able to perform the activity under direct supervision. Level 3, the trainee is able to perform the activity under indirect supervision. Level 4, the trainee is able to perform the activity under distant supervision. And finally, level 5, the trainee is able to supervise others in this activity. So the difference between level 2, 3 and 4 in practice is that at the level 2, the trainer is standing beside the trainee. In level 3, the trainer is present in the next room, and in level 4, the trainer can be reached by phone. So this reflects how clinical training is done, and it formalizes that, and it allows us to define a level of entrustment or independence, if you want, for each of these EPAs. You see that in this table. This is part of the core curriculum. And also for each of the procedures. This is on the second part of the table. So coming towards an end, the new core curriculum for the cardiologist is based on EPAs for different reasons. One good reason is that EPAs focus on skills, but also integrate knowledge and attitudes. And because EPAs focus so much on skills, they are really ideal to assess a trainee repetitively during training, so that it will be documented during training what level of independence the trainee has reached, and this will facilitate further training because it shows where the weak spots are the trainee still has. Of course, knowledge and attitudes are also covered in EPAs, but it is better when knowledge is additionally assessed in a separate written exam. So for this purpose, we have decided to send all our trainees to the European exam in general cardiology, and so far we have made a very good experience with that, and we are convinced that that was a very good decision. And finally, the attitudes part of clinical competence, in other words, the way you behave as a trainee and as a physician, as a cardiologist in clinical context, that should be assessed in addition to the written exam and in addition to the EPAs by multi-source feedback. So if you think about this concept of EPAs for the new ESC Core Curriculum, you realize that this concept demands a lot from the trainee, but also from the trainer. The trainee is supposed to be motivated to learn and to actively go for assessments in the clinical context. So the trainee should approach the trainer, and that's important, different trainers, not always the same trainer, during training, and perform assessments in a clinical context. The idea being that each of these assessments focuses on one specific EPA. And logically, a single EPA, a particular EPA should be assessed repetitively during training. So that means that we will perform more assessments during training, but this is for a good reason, because it shows where the trainee stands. in a way, this is a formalization or a more intense use of the DOPS system we already have in Switzerland. The trainer is also put under more pressure than it has been the case previously, because the trainer is supposed to be available for these assessments, and the trainer should show commitment for training the trainees. The trainer is responsible that the trainee gets feedback, gets assessment, and gets the opportunity to increase the levels of competence to the desired level defined in the core curriculum. So this is my last slide. It points towards something very important, and this is formalization of assessments using EPAs. We are convinced that we need to develop apps working on computers or smartphones in order to take care and take track of these many clinical assessments which we demand with this EPA system. And there are such apps. We are working on such apps already in the background, and we hope that we will be able to provide them very soon. And basically, such apps allow the trainee and the trainer to meet virtually with their devices, their iPhones, and document the result of the assessment of the EPA in a predefined manner. And in a way, such apps do not only facilitate documentation, they are also like a track record and give you the overview of your competence levels in the different EPAs contained in the core curriculum. So we have really an important double function of such apps. One is they reduce the documentation time, and this is something we want, because we don't want the trainers to invest too much time in these assessments. So at least the documentation should be facilitated. And the other thing is that both the trainer and the trainee have the overview of which EPAs have been completed or which EPAs should still be completed or at least reach a higher level. So this is my last slide. The new ESC Core Curriculum for the cardiologist will be published soon, so by the end of August, and afterwards we will work with the Weiterbildungskommission in implementing this in Switzerland. We are not sure yet whether we will have to adapt it in certain points, but I feel quite comfortable that the major part we will be able to adapt the way it is. Should you have questions regarding this new core curriculum and its implementation in Switzerland, please contact me via email. This is felix.tanner@usz.ch. Thank you very much and have a good day.